You can. I'm happy to chat later too.
Good afternoon. Welcome to Grand Rounds today. As I generally do, I will ask you to sign the attendance record at the back of the auditorium and also fill out the program evaluation and give us any ideas you might have in regards to future topics or future speakers. Today, it's my pleasure to reintroduce Dr. Greg Welk. Dr. Welk is a professor in the Department of Kinesiology at Iowa State. He has been extensively published, and he's a well-recognized authority on the topic of exercise and its attendant health benefits. And CME committee is quite pleased that he was able to accept our invitation today to review with us the Exercise is Medicine and Walk with Ease programs. And please join me in welcoming Dr. Greg Welk.
Thank you. It's a pleasure to be here, and I have been fortunate to do several of these Grand Rounds talks. So I always mix it up, so it won't be the same talk you've heard before if you happen to come to previous sessions. But the themes are similar. So as in kinesiology, my focus is really on health promotion. So I teach community health, worksite health, and my research is also aimed at studying how do we build systems into different settings to impact population health. So I'm really a public health researcher. I'm interested in how do we, translate programs and get them to be sustained over time in different places and to impact not just locally but nationally. So the Exercise Medicine is Medicine program is one initiative that puts a nice structure around things. But I do work in schools to create school wellness. I do work in work sites to create adult or employee wellness. I'm interested in community programming and outreach and do work with local community agencies. And here I'm actually, visiting about clinical partnerships. So to impact healthcare through similar systems, we are, sharing our programming with you. So before I begin, I did want to introduce a colleague of mine, Allison Phillips. So she's sitting way down here in the front row with me, but she's another colleague that works closely with me. She's in psychology, and our work on this is a team effort. And we're actually, what I'll be sharing with you today is our local programming on Walk with Ease, but we actually are working with a group called Community Health Partners that's based in West Des Moines, and they're coordinating Walk with Ease at the state level, and they're just one of several states that's coordinating this nationally. So I'll try to describe that whole scope and scale to you and kind of move forward. So as I mentioned, I've shared with you this vision of exercise is medicine, and you'll hear me go on and on. That's my mantra, and I really do believe it, and I hope all of you would as well, that exercise truly is medicine. It's more than that, but it is medicine. And we have a local campus student group called Exercise, so we can spell it in a nice, fun, creative way. And so in past talks, I've visited with you about some of the work we do with activity monitors that offer opportunities for exercise is medicine applications. And we've also talked about health coaching. So we have a whole motivational interviewing training practicum that we train students to be health coaches. And then we've had some of our health coaches work here through Mary Greeley and working with McFarland. So that's one project, and that's a great program. It's great for students and the patients, but the limitation of our health coaching model is that it only reaches individuals. And so, Dr. Halberg and Dr. Skinner have actually talked to us over many years and said, well, it'd be great if you could come up with a program that we could refer groups of people. Well, that's what Walk with Ease is. So it's a simple, easy, and evidence-based program that we can refer people to, or that you can refer people to, and we would take over from there. And it's a simple program for adults, and it works. And the advantage of this is it creates a larger opportunity to impact populations or larger groups of people. And then as we scale this up across the state and country, it really can impact population health. So I'll move into the details here. So this is the logo and vision of Exercise is Medicine, and I thought I'd remind you of that in case you haven't heard of this, but it's a major initiative of the American College of Sports Medicine, which is the professional organization for people in kinesiology, and it's really taken root not just nationally but internationally. So there's hubs across not just the U.S. but across the world, and health systems like Kaiser Permanente have fully embraced Exercise as Medicine, and one of the goals is to have exercise be tracked as a vital sign in the electronic medical record. And I'd be thrilled to talk to anyone about opportunities to do that and the advantages there. But I'll be talking more about the referral process and what you as clinicians can do to refer appropriate patients to programs like Walk with Ease. But this is one of the this summary really of what exercise medicine is about. So if you read it, what if there was one prescription that could prevent and treat dozens of diseases such as diabetes, hypertension, and obesity, and many other conditions? And the answer is obviously exercise. So it's a simple pair of shoes and it's a simple behavior change. Unfortunately, as Allison can say, it may not be as simple as we think. Many people find it hard to take this medicine. Some of us find it relatively easy. You get up and you go for a walk or you add activity into your day, but some people find it really difficult to take this medicine. And it's, so I always like to say it's medicine, but it's also a lot more than that. It's quality of life and it's independence and it's many things for seniors. But you guys as clinicians can really offer that impetus to get patients to take that step. And I use the pun intentionally there of taking a step to start being physically active, because it avoids the barriers and issues that many people might have about exercise in the past. So the EIM agency or association actually uses this slide. So I borrowed this slide, but it says physicians should prescribe it and patients should take it. And they use an interesting analogy here that they say instead of an allergy, and I hadn't really thought of it that way, but maybe some people view exercise as an allergic reaction, like, yeah, it makes us sneeze or have coughs or allergic reactions. But so some people really have an aversion to exercise, whereas others find it very pleasurable and enjoyable. They use this example of a pill bottle, and to fully capitalize on the commercial potential of this, our local club made our own Exertol. So this is a joke, obviously, but you can grab your Exertol bottle up there if you'd like. And since I did disclose that I have no financial obligations, it is free. So obviously, I'm your local physical activity rep selling you pharmaceutical quality exercise in a box, and there's obviously nothing in it because exercise is free and it's open to everyone. But we had fun with the product because there's so many parallels to exercise as medicine. There's been thousands of randomized controlled trials, for example, that have demonstrated that exercise works and that it's safe, and we have guidelines on how to prescribe it, and we have so there's dosages and there's cases of where it works for different populations and how to make it work better for other populations. And there's appropriate warning labels here. So if you want to look at your box, it says this prescription may result in weight loss, improved health, better self-esteem, and quality of life. So be warned. We also say, do not keep out of reach of children. So it's, we had fun with it. So if you'd like additional boxes, if these run out, we have more. And so I'm happy to get them to you. They're kind of a nice conversation starter, and they could, go on your desk and remind you about prescribing exercise. All right, so that's a little fun story. So this is the insert, and we did work pretty hard to have real guidelines in here, so you can grab the insert and have this. And one of our thoughts is we could pitch Walk with Ease through a box, putting the insert inside there, but I think you get the idea of that exercise is free and available, but you have to do it in the right way and have some support. So here I'm going to talk today about this Walk with Ease program. It's an evidence-based physical activity program developed by the Arthritis Foundation, but we're working with community health partners to launch this across the state. They work through a lot of YMCAs or other clinical community outreach centers, and so we're working to develop systems to train and standardize how these agencies deliver this program across the state. But we also wanted to have a local program, so that helps us learn the program and also provides local benefits. So I'm really passionate about community outreach, and this is one way that we give back. So even though we teach and do research, this is service to us. We want to serve patients and clinicians in Ames and Story County, and so this is one way to do it. And my other passion is to try to integrate the work I do with students and teaching. So our program will be led by students who are trained by us and also through the Arthritis Foundation training programs to learn how to work with seniors. And we have a steady supply of students, and you guys would have a steady supply of patients, and that's what allows us to make this program available for free. So I'll walk you through all that. To get started, I thought I'd give you a little bit of a video from the CDC. This is on their kind of vision of arthritis and strategies that have been shown to work with arthritis, and that'll lead me into Walk with Ease. Okay, good. Well, that just gets you the flavor of the impact of arthritis in our population, and it's an increasing problem as our aging demographics show. But there are strategies to address this. So Walk With Ease, again, was developed by the Arthritis Foundation, but as it's evolved, they're more than aware that there's many populations that would benefit from this. So it's not exclusively for arthritis patients, it's for any older adult population that could benefit by starting out a physical activity program. So it's not a fitness program for people that are already active, it's for people that really need to start a physical activity program and build confidence along the way. So the CDC actually has detailed web pages, many of you have probably been on these, that talk about different evidence-based programs. And so this is their lifestyle management programs for arthritis. And as you can see here, it describes promising programs or programs with promising evaluation data in which are building the infrastructure to support program delivery across the country. So that kind of alludes to the importance of system change and translational work, where we want to start with programs that offer that possibility to be scaled, to scale up and impact the population as a whole. And one of the things I've liked about Walk With Ease and why we got involved is because it is scalable. It's a simple concept, but it really can be easily implemented and translated and scaled up. So that's why we're working with the Arthritis Foundation and CHP to do that. And so on their website, they have recognized Walk With Ease as one of their promising or recognized programs. And it, highlights the things that it's been shown to do in the past: improve balance and strength, improve arthritis or reduce arthritis symptoms, increase strength, reduce falls. So many benefits have been attributed to the Walk With Ease program. Now, we won't have this pretty grassland to have people walk on, but we will have facilities and programs available to allow the patients to get walking in either individual or group settings. So the key, though, is for us to implement this program is to start with all of you as healthcare providers. So we could offer this program and put up flyers on campus and attract a certain number of people. But what we really want to do is reach the right people. We want to reach people that need this treatment the most, and that's why we're starting with all of you. So we've set up the project where it has to have physician approval. We do that for a couple reasons. One, to make sure that, again, we're reaching patients that need it the most, but also to ensure that they're safe to exercise. So in most cases, whenever somebody would start an exercise program, if it's an intervention we're running on campus, we have to have physician approval anyway. But we're just starting off with that as a prerequisite, basically, so that we create that dialogue between the patient and the provider, or the provider and the patient. So as you're thinking about this, you could say, well, I know just the right, or if you're talking to a patient, you could say, I know just the right program for you, and hand them a flyer, and they can talk to their physician, or the physician could have these in their office and mention it to their patient. So there's many different ways that we're going to implement this. We actually just had approval now to also offer it at Northcrest and Green Hills and other places. So we basically can offer it at other settings that approve to let our team come in and host a group walking program. And we also have approval to run a self-directed version of Walk With Ease that would allow people to do this on their own with a workbook and with a personalized health coach. So that's where the health coach piece comes in. So I've leaped ahead a little bit, but let me take some steps back and explain how Walk With Ease works within the exercise medicine model, and then I'll show the role of healthcare and the role of clinicians before I get into the specifics of Walk With Ease. So again, this is your role as clinicians, healthcare providers, physicians. The patients are going to come to you and they're going to take your advice. And so if you remind them of the importance of exercise, they'll hopefully start believing it. You'll see on the left, the joke is really that people still don't believe it. But you guys are our best asset, and people will trust their physicians and healthcare providers that this is really something that's important for their health. So we go over the top a little bit to explain this, but the average person knows physical activity is good for them, but they're always looking for a shortcut, right? They're always looking for, well, what could I do that makes that easier? Well, the answer is nothing. Exercise is pretty easy. Just 30 minutes of walking most days of the week is enough. And so it can be a part of their lifestyle. So it's relatively easy to get the benefits of physical activity, but it's got to be a commitment by the person and something they embrace. So again, the Exercise Medicine Initiative is designed to facilitate that referral process. And so it's, again, a global initiative, and it's focused on transformational systems change within healthcare. And so there's small steps happening all over the country, and I've shared this vision with all of you here. And the steps that I'm taking now is a really good example, because we're going to rely on you guys as clinicians to help with that referral process. And this is a similar graphic I've shown you before, but like most programs, they've continued to refine this solution. And you'll see that they've highlighted community resources and active health technology in this process. So instead of it just being clinicians on their own assessing, prescribing physical activity, it now emphasizes the importance of community referral and also technology applications. So again, healthcare providers initiate the solution by incorporating physical activity into clinical care. This could be in a formal way where it's done, again, through an electronic medical record, or just informally, reminding patients almost every visit about the importance. And so they emphasize these 3 different steps. So one would be an assessment, another is a prescription, and then the third is a referral. So I'll walk through each one of those. And these slides are kind of long, and don't bother trying to read them. They really are just capturing the 3 steps. So physical activity assessment is the first step. You have to know, is the patient doing physical activity or not? And that could be done, again, formally or informally. So they've developed through the EIM program a simple 2-item survey. It's called the Exercise Vital Sign, and it's just these 2 questions. On average, how many days per week do you engage in moderate to strenuous exercise? And then on average, how many minutes do you engage in exercise at this level? So do you do it, and how many minutes? Simple questions, and you can get a sense of if a person's physically active or not in your own way. But in many clinical settings, they've actually integrated these questions into the medical record so that they're real data that you see over time. And then if a patient changes their habits, you would see it in their record. The second step is prescription. So if you start knowing what the needs of your patients are, then you could prescribe exercise just like you prescribe other things. And one of the challenges is that exercise has many different implications, and you might have to prescribe it differently for different conditions. Well, the EIM Group has made that easier as well. They've developed 45 different handouts. I guess these could be made available to you if you'd like. But I've given you a sample up there, but this would be exercising with type 2 diabetes. This is exercising for COPD. This is exercising to lose weight, and I highlighted exercising for rheumatoid arthritis. But these are all downloadable, free, and they're really nice handouts that you can give to a patient and or refer. So you'll notice on the back side of these, it specifically says referral. And so that's the third step. The third step would be that healthcare providers can say, well, I can't deliver this program for you, but I know just the thing, or you can go to this program or that program. And so what Exercise Medicine is working on and towards is to have approval processes to make it easier for clinics to refer to evidence-based programs that they know are well-run and quality. And that's, I guess, why I'm here today, to convince you that Walk With Ease is a good option for you to refer patients to. So that's the community resources. So I'm going to share with you now what this one program looks like. It doesn't have to be the only one, but it is a program that is ready to go. So again, EIM highlights that utilizing community resources to create a referral networks can help serve the patients that need it the most. And that's why, again, we're starting with this referral process and requiring patients to talk to their provider to get that approval. If you haven't seen our handout, this would be the flyer. And again, at the back, there's a specific handout or place where you would sign. The program also emphasizes the importance of what are called physical activity intervention advisors. These might be called nurse navigators or other things in different settings. And I don't know if Lisa Barnes is in here. Are you here, Lisa? She's been one of my biggest champions in trying to get this to connect across Mary Greeley and McFarland, and any of you could help in a similar way. So we know that it's difficult, but this communication between and within the hospital setting and between the providers is really important. So Lisa's been helpful in initiating some of that communication and referring, and we do have some people that are starting to call through our system. So they can log online through our exercise.org website or email us at exercise@iastate.edu, and we would get the emails and handle the referral from there. We'd ask them, do you have a referral process? And so we're ready to go. We're launching programming in the next couple weeks. weeks. One of the really novel things about the way we've set it up also is that a person can start at any time. So unlike most programs where you'd have to start at, say, February 1 and then everyone's in it together, we've set it up so that patients can enroll in their own 6-week cycle. So they would start when they want and they would finish when they finish. And then we would also help them sustain things over time. But again, I was highlighting the advisors as a key connector between the clinic and the community. And exercise medicine emphasizes the same thing. They use this bridge analogy of building this bridge between the clinic and the community. And so again, that's one of the strategies I wanted to highlight here today. So this is some slides I've adapted from the Arthritis Foundation's description of exercise or walk with ease. And I wanted to highlight a couple things about that. And one is that the word is simple. It's a simple approach for promoting walking. And as I go through this, I wanted you to remember that there's nothing magical about the program per se. So just like there's no single diet that works, there's no single exercise program. What works is physical activity or exercise. So it's up to the participant or patient to do the physical activity. There's no specific program that'll work better than any other program because it boils down to whether the person is doing the behavior, right? So I like to emphasize the simplicity of walk with ease because it puts the onus on the participant to engage in the walking, and it holds them accountable either through a group or self-directed format. And that's the magic. It's not the program itself, it's the physical activity behavior that the patients are taking on. So this is how it works in Iowa. So there's this agency called Community Health Partners that, again, is coordinating this across the state through different clinical partnerships and through YMCAs. And they're actually working on ways to feed that data back to clinicians. We don't have, our local program doesn't have that built in yet, but the CHP is working on that. And that's one of our goals of our statewide effort is to figure out how clinicians can refer patients automatically, and then they would get that information and data back. But this is, again, led by community health partners, mostly through YMCAs, but then also in partnership with the Iowa Physical Therapy Association. And all the programming is led by specialists that have completed this standardized Walk with Ease training. Our local program, so I highlighted this in Iowa State colors, is led by our ISU exercise program in partnership with our exercise clinic. So our exercise clinic is the parallel of a YMCA. If anyone's seen this facility in the Forker building, we have, it's really nice group exercise format, all kinds of exercise equipment. For Walk with Ease, we would let seniors be walking around the perimeter, and they would have access to some of the stretching mats and things like that, and we would, guide them through a group exercise program just like we've done with the exercise clinic for many years. And it'll be led again by students, in this case, that have been trained by us and through the Arthritis Foundation training courses. And again, our handout's there. So to give you a little bit of background, it is an evidence-based program, so studies have shown the benefits on reducing arthritis symptoms. Oh my. I saw that happening. Are you okay? We didn't notice, don't worry. No. All right, so yes, it is an evidence-based program. That's always one of the first questions people want to know. Does it work? And so it has been shown in research studies to that it can work in both the group and self-directed programs have similar benefits. We're actually very interested in that question. And so one of our goals would be to study whether better outcomes happen from a group dynamic or individual accountability with a health coach. So that's one of the things that we'll make available. But unlike most controlled studies, we'll let people choose. What group do you want to go into, group or self-directed? So the target population, again, was for mainly arthritis patients, but it's been wide open for referrals. So any clinical population or patient that would benefit from a structured physical activity program is eligible. The inclusion criteria is they have to be able to stand for 10 minutes without pain. So it's kind of starting at a low level of functionality, and that's intentional. So we don't want people that are already physically active and already know what they're doing. We want to start with the patients that need it the most. So again, there's two different options, self-guided and group, and they both are designed to accomplish the same goals. Some people like a group setting where they can work with others. There's kind of the group and social dynamic. Other people would say, no, I'd rather do this on my own. I want to just look at the workbook, look at the online materials, and be independent. And so both are equally good. They're both designed to accomplish the same goals, but we've supplemented the self-guided version with our health coaching hub. So now if a person elects to be in the self-guided version, they could choose to have a personalized health coach kind of work with them during those 6 weeks. So again, it's self-paced, 6 weeks long. For the group one, it's designed to meet like Monday, Wednesday, Friday, so people are asked to walk 3 days a week and get their physical activity in. So the goal is to build to 30 minutes or more 5 days a week. And there is reporting through a mobile app or workbook, and we've added a physical activity monitor to our version of the Walk With Ease program. So what's in the workbook? Information about arthritis, walking instructions, exercise, motivational tools, strategies. So it's a standard booklet. But again, my point earlier is that the booklet's not magic. It's the reading it and applying the information that's going to be the magic. So the workbook gives really good resources, but it's up to the person to take that medicine as well and read the information and act on it. So the booklet includes steps to establish a baseline, so kind of self-guided, logging where they can log what they've done in the past, what's worked for them in the past. Then a goal setting page. We all know the goal setting is an important behavior strategy, and writing it down is really helpful because when you commit to it, then you're more likely to stick to it. I guess how many people are still working on their New Year's resolutions? Some of us let those slip, but it's okay. So, you just get back to it next week. So there's nothing magical about January. It's about starting again. So and that's what you have to commit people to is if you fall off the goal, you just start again. So then you assess progress, and there's self-guided ways to do that, and also ways to evaluate progress in the closing steps. So it's 6 weeks long, kind of guides them through in their own way and self-guided in that regard. There are available tools that make this easier. So it's designed, again, to be for people to use online, really simple web interface. There's a mobile app. So we know that many of the target population are going to be seniors, but increasingly seniors are web savvy and have their own smartphones and can navigate these things. But it's, again, not required. They can use the booklet and get guided through the program on their own in the same way. But there are other resources to take advantage of there. So these are some quotes by people that have been using Walk With Ease. So, it's fun to read these. These are actual quotes. So feeling better and building friendships are two of the main program incentives of Walk With Ease. It gave me a lift for the day, not only physically, but in my mood too. And I think you all kind of appreciate these are tangible benefits that people would feel after they start a basic physical activity program, and that after they see these benefits, they're more likely to look for other benefits over time and hopefully stick with it. So we've made a number of enhancements to the project locally, and they're all additive. They're not going to be changing the existing program because we want to make sure that we keep it consistent with the state and national programming. So ours will be consistent with all that, but we've added features that'll enhance it. So it's an IRB-approved protocol, and that's really important for us. We always want to make sure that the participants know that they're in a safe and approved program, and that it also provides protection for the students that are working with them because they're not licensed professionals yet. So they need kind of to know that this is a research study. So it's full disclosure. It kind of lets everyone know that this is an approved study and that a participant is choosing to enroll in the project. Again, we've also added, I guess I didn't mention this, additional personalized fitness evaluations for patients. So this is not built into their kind of state level program, but we have the capabilities and the expertise to do really well done adult fitness assessments. So we've added those. I'll show you a little bit of examples. We're also incorporating monitored technology that builds on kind of the work we do in our labs to facilitate self-monitoring, and we've added this health coaching component to facilitate habit formation and behavior change. And this is something we're also doing statewide. So literally, if people choose the self-directed option anywhere in the state, they would get linked to our telephonic health coaching team, and they would work with the person, individually over the phone. The advantage for people here is that we can meet one-on-one with them in person or by phone if they choose. But we're actually serving the state hub in providing telephonic health coaching to people, using it anywhere. So this is our evaluation plan. So it kind of shows, it's more of a research diagram, but it shows that a person enrolls and they could choose one of these three options: self-directed with a health coach, or the group program. But all the things are the same. The assessments are the same at both pre and post. And then we have a 6-month follow-up so we could evaluate whether people have sustain the programming. And that's where we're kind of interested in finding out, did they stick with that behavior over time, and did they retain some of the benefits of reduced pain or reduced symptoms or reduced falling. So we're actually very interested in fall detection. I know that's a topic of considerable interest among the clinicians, and Walk With These is not yet linked as a evidence-based fall prevention program, but the data we're collecting will allow us to, maybe have the information to make that leap, I guess. So, because I think the behaviors that we're targeting are very consistent with the fall detection behaviors. And to that point, these are the assessments that we include, and 3 of them are part of the STEADY recommended functional assessments. Are people familiar with this STEADY intervention or guidelines? So these have the 4-stage balance test, 30-second chair stand, and 10-foot up and go are the 3 of them that are recommended in this STEADY assessment rubric. And so if clinicians are already using this, we're going to be assessing these indicators pre and post. The patients can share that data back with you, but we don't have permission to share it directly. It's up to them. But if they're referred and they bring it up and they have their handout and personalized fitness report, you can ask them to, or, can I see it? And you would see that progress, and that's the kind of data we're tracking. We're also building plans for just providing a fitness assessment separately. So if clinicians want to refer to a fitness assessment only and get a report, we can also handle that. We haven't built that into this particular program, but it would be a separate type of referral. You would just refer them to our lab for a fitness assessment, and then they could decide then if they want to do Walk With These or not. Because we know these assessments take time and they're hard to do in a clinical setting, but we have the space and resources and training to do it. So again, these are going to be really nice indicators to show progress from pre to post, and then the goal is to see if these are retained after 6 months. The other innovation really is this integrated monitor technology. So I've done lots of work with these different gadgets over the years, and we've recently embraced this relatively simple device, this piezo RD monitor, because it's designed for clinical integration. So there's many different research grade devices out there, and there's also many different consumer grade devices like Fitbits and things like that. This one's kind of in this happy medium. It's really simple and easy to use, but it's designed for integration into healthcare settings. It has a really big display with, and it really just tracks steps. But increasingly with these devices, they're more than just step counters. They're actually accelerometers that are tracking movement on a minute-by-minute basis. So they can record whether it's moderate intensity activity or vigorous, and they could differentiate sitting and standing. So these monitors have gotten pretty advanced these days, and these are one of the less expensive version. And again, they're really well designed to facilitate use by patients and also into healthcare. The other innovation is this clinical health coaching. I just included this handout that I've talked about in the past talk, where we've built a training model where we train undergrad students to be clinical health coaches. And so some of them, again, have been working with different offices here in the hospital, and they're trained through a practicum course working with peers first before they could take on patients. So we would guide them through this 2-credit course, and then these, after they meet that requirement, then they would be eligible to do the self-directed health coaching with Walk With These. So to get to the last section, this is again getting into the EIM solution. It's the active technology. And so I wanted to conclude, I guess, with some visions of what's possible in the future. The future is happening really quickly, so it's hard to believe it's really 2020. But now we're moving into new eras with healthcare as well. But the real vision of clinical integration and community referral is for that data to come back to the clinician. So right now, there's no system to really make that happen. So physicians can refer to other programs, but there's not data that comes back into their system yet. But Community Health Partners is one agency across the state that's working on that long-term vision. And so we're really excited to help them along the way, and Walk With These would be one program that we're piloting to kind of test that kind of linkage. So this kind of summarizes the vision of clinical integration. And again, this graphic's more from the Exercises Medicine hub. So we're following this model to a great extent. So you see at the top, there's healthcare providers that are referring to intervention advisors or navigators to get people into qualified programs, but there's also healthcare payers, and the payers would in theory be reimbursing the clinics and programs to offer evidence-based programming for their patients. And the whole insurance scenario has to be worked through, and the providers and the programmers have to be connected, but public health also plays a role. So that's where kind of my world is. And so our interest is in building and testing evidence-based programs so that they can be scaled up and made available for both the healthcare providers and the payers. So it's that synergy between the providers, the payers, and public health that kind of connects to deliver evidence-based programs and builds that community clinical network. And so they refer to it as an active health IT platform, and moving from engagement to outcomes. And I kind of like those analogies of, it starts with some engagement at the patient level and then moves to, outcomes that we're all interested in. So in the past, I've shared with you some of my own work with wearable technology, and this gets at kind of that same example. So again, if you go back to this physical activity vital sign, one of the things that I've been interested in is if these two items were used in a office visit, just like you would check blood pressure, you would have these data built into an electronic medical record, and then maybe the clinicians can say, well, let's see if let's check your evaluation or your physical activity in a more robust way. So just like you might say, well, let's send you down to the lab to get blood drawn and look at your metabolic profile, you can refer them to wear monitors for a week. And so then if you had objective data, then you would be able to compare that to the self-reported data and see if their activity levels are really what they need to be. Then you could, again, do the referral. This shows kind of referral to a health coach, but you could also refer to a healthcare provider. So this is one of the synergies I'm interested in from this clinical community partnership. And this is the challenge. So the vision of integrating this mobile technology and getting this data back into the healthcare system is really challenging because these devices all have different assessments and different outputs and different export functions. And so it's really hard to standardize all these different gadgets and get them into one system that healthcare can use. But there's a lot of work going into that. What I like about the Walk With Ease program is that all this can be done in a more streamlined way. So this is a picture out of our state level effort with community health partners where patients would enroll in Walk With Ease. They would work through either the piezo monitor or with the CHP Connect platform, and that would link back through Validic to clinical integration. So again, we're working on it. We're not there yet, but this is kind of our vision for how to take evidence-based programming, have people participate in and track that data, and then feed it back to clinicians so you have this information for future visits. So I think I'm going to leave it there. I can take any other questions, but our conclusion, I guess, would be that exercise truly is medicine, but we really need to develop ways in which we help people take that medicine and can sustain their dosage over time. And this integration of clinical community partnerships is one strategy that I think will make that possible. So I guess this is a group of students that helped me with a lot of these, and I mentioned Allison, and it's really a team effort. There's many, many people that kind of do this work in our department and across campus, so thanks.
A question and an observation.
Yep.
When people start a program such as this, whatever the program is, what's the likely or what is your measurement regarding the people that stay with it for a significant period of time, whatever that is? And the observation is, about half my practice lifetime, I worked here at Mary Greeley at the McFarland Clinic. I walked to work. I was lucky. 1 mile. I live 1 mile from the McFarland Clinic, and so I walked to work summer and winter, regardless of the weather, unless it was raining. And when I retired, the urge to go to the clinic every day was not there because I was not working anymore.
Sure.
And I find that my activity level for walking decreased because I didn't have the motivation to continue walking because I was obligated to go somewhere every day at a given period of time, regardless, and I had no other schedule that could conflict with that. So my observation is that the motivation is not easy to build or to find for each individual person, which may vary from person to person,
Exactly.
that will keep them within a particular program. You want to make any comment about that regarding motivation and also about the people who stay with the program?
Yep, we study that actively, so that's an area of interest for both Allison and myself, when we study this. So the reason that the Walk with Ease is useful in this regard is we'll be able to compare self-directed versus group. So some people really benefit from a group structure, and that's that accountability. Other people might prefer a self-directed program. Our program will allow people to choose which one feels better to them, and again, to get the help from a health coach. So the goal of health coaching or the group would also teach those behavior skills that add the motivation that you're describing. So you had it initially on your own, but then maybe other people find it hard to sustain that, and we all need this help. It could come down to, reminders that we give each other, spousal support, community support, or the health coach support. So there's different ways in which we each keep that motivation over time. But we actually study these very things. So in the outcomes, we'll be able to look at the factors that predict those that stay on and retain these behaviors for 6 months versus those that don't. Allison and I and another colleague, we actually did a study similar to what you're describing. We gave people Fitbits and we said, okay, here's how they work, here's help in using them. And we tracked what happened to the use of their Fitbit over 6 months and longer to try to study why do some people sustain the use of that and maybe other people don't need it. I don't know, Allison, you want to comment?
Yeah, the general answer is to get something to stick long-term of behavior, there's 2 ways to go about it, and both are important for something like physical activity. One is to make it as habitual as possible, right? So it's integrated into your daily routine, it fits into your routine, and you don't have to tweak things around each and every day or when the season changes, right? So it has to be efficient and fit. But the other thing regarding motivation is you have to get something personally from it. So it has to be rewarding in some way. And that's kind of the harder part for most people to maintain over time. But that's what my research focuses on. We're figuring out ways to, for example, get people to be intrinsically motivated to be active. They actually enjoy it. Right? So it's not drudgery. They enjoy whatever activity is they've chosen. It might be the group aspect that's really the only rewarding part, and that's okay. But if you were to stop exercising, you'd miss out on your social support, then you're gonna continue it. Other motivation might be through identity, right? It's part of who you are. If you were to stop doing it, you would feel bad, very broadly, and so you'd be motivated to pick it up again. Or, we study people who have heart attack or stroke or injury. What predicts whether they pick up something new? They adapt. It's really both of those things. Did they have a habit beforehand, and is it part of who they are, and do they really get enjoyment from it? So it's the tricky part is how do you help people get to that point who otherwise think it's an allergy, right? Exercise is an allergy.
Yeah.
Yeah, thank you for your talk. So I have patients that will go out for a brisk walk 5 days a week, and that's good for them. Then I have people that are out there, they go out for 3 hours. And then, of course, some people don't go out for anything. So there has to be a plateau in there as far as, is it good for you cardiovascular-wise, musculoskeletal-wise, or do you see that plateau somewhere out there?
Right.
As 2-3 hours or?
Sure. I mean, the weekend warrior syndrome has been studied a lot, and so there's a lot of people that just work out on the weekend. And, while it might not be the ideal model to get all your exercise in one day, it has been shown to be to have benefits still. So there's risks to the person, but if that's the way they get their dose, it's better than not doing it daily. Or better than not doing anything, I mean. So the trick or interesting thing with exercise prescription is it varies by the individual. So that's what, to a person that's just starting off, those 5 days a week of getting 30 minutes helps them have a base level of fitness. But after you have that, if you want to improve your fitness further, you have to do more frequent, more intense, or longer. And so that's what happens as people move up if you keep wanting to improve your fitness. Fortunately, that's a choice at that point. And most of the health benefits are captured in that 30-minute, 5 days a week. So if we can get the population doing that, that's what we need. Choosing to do more than that is optional. It's a personal choice of wanting higher fitness, not just base health fitness. I don't know if that kind of answered your question, but it is very individualized. So we, in the fitness industry or field, we, would study people's baseline levels and then prescribe exercise according to their individual levels. And I think that would make sense to most of you, that we all have different baseline levels.
And then kind of a different question. If you have a 65-year-old guy, he has a little bit of knee arthritis, some low back problem, and you're trying to get him into the right exercise, some of them will push and push because they've heard or feel that some jogging is better than nothing, and do some walking and some intermittent jogging. Is that really better for them and their knee hurts a lot afterwards? Or should we just keep them at, just stick with the brisk walking is better for you overall? Is it just the miles that they put in as the significant factor?
Yep, but I think being somebody that has those type of knees already is, I have to accept that slow running is better than no running, but I also think it's again up to the individual. If they want to be in it for the long haul, maintaining their joints and their body by walking is probably a better long-term option than trying to do the jogging, because if it's not working for them and they're feeling pain, I think that's a warning sign to maybe stop and not do it, or not to do it every day for sure. So adding a little bit of vigorous activity is beneficial, but again, it's up to a personal choice, and we'd want to make sure that they're safe to do jogging, whereas, brisk walking gets you most of the benefits that you need.
Okay, thank you.
Yep.
Thank you for your talk. So at the end of the 6 weeks, let's say my benefit, my motivation has been I've enjoyed the group or I like the facilities. What happens at the end of 6 weeks?
Yep.
Do I, I guess selfishly from, referring somebody if they love exercise and they continue, that's great. But what if I am that person? Can I still go to Forker? Is there still options available to me?
Yep, we have anticipated that need exactly, and so through the exercise clinic, that's what they do. They offer these group exercise programs over time. So our vision is after a person, let's say, graduates from the Walk with Ease structured program, then they could elect to stay on and participate on their own in the exercise clinic. And as long as we have, more students staffing different hours, we can open additional hours where people can get the advantage of the exercise clinic over time. And we're also planning to, as I mentioned, maybe offer this at different retirement centers like Green Hills or Northcrest. And if we do that, if there's a person there that is in charge of that program, the walking can continue. We can get students over there to supervise the walking, and that type of group dynamic can continue. We've done, through our exercise medicine, we've already done partnerships with those centers, and we have a program we call Bingo Size that's really popular there. So they play bingo, but when they get their bingo, they have to stand up and kind of move around. So it's designed for chair exercise, but it gets a lot of the seniors moving in a fun way, and they really have fun with that. So we do have other follow-up programs after that.
A few decades ago, it was a big thing to put weights on your arms when people were walking. And we know that the muscle mass of the bicep is more important even for cardiovascular risk than weight is. So do the programs incorporate walking with small weights?
That would be up to the individual. So it's we would self-guide them towards their own pace and their own options. So there would be weights available in the clinic as they move around. And so for some, walking might not give them the intensity they want, so they could do walking while they're holding a few dumbbells or something. That might be fine. So it's some individuals are going to be at different levels than others, so we would kind of guide them on their own. The other thing that I want to mention again is how the self-starting process works. So each session, they would get like a group discussion. The leader would meet with them and talk to them about tips and exercise for the week. So a little bit of content knowledge. And then there'd be stretching and kind of warm up, and then a group walk or an individual walk. They could do it on their own, and then they'd finish. But we've set it up so that a person can start at any week. So each of the talks would be different. So talk 1, 2, 3, 4, 5, 6. But if somebody starts at week 3, they would just do 3, 4, 5, 6, and then 1, 2, and finish. So everyone can start and stop at their own time, and then that's where they would get connected to the group in a social way. Oh, we've got a new member, and they would join the group. So that's at least the concept of the group dynamic there, and it would be self-guided with our exercise trainers there to help. Any other questions? All right, I guess, again, my final request would be grab the handouts on your way out and let me know if we can, we'd really appreciate the referrals. As I said, we're here to serve you and also you're here to serve your patients. So I'd like to make that circle complete and have us serve the patients with you. So thank you.